So question number 21. Okay. So, okay. 26 years 26 years old 26-year-old woman para 2 gravida 2 para 2 has an increased fatigue, depression, dry skin, constipation, and cold intolerance. She weighs 9 kg less than 6 weeks of postpartum. 3 months ago, she required a transfusion of 3 units of blood following the birth of her second child. She once she was unable to feed her she was unable to feed because her milk never came in. Mens has never resumed. Which of the following is most likely cause of this patient? Uh, okay, it's Sheehan syndrome, isn't it?
Oh no, wrong way. Sorry. Yeah, probably. Okay, so she has post. Is C the answer? She has postpartum hemorrhage. Is defined as delivery-associated blood loss greater than 500 ml for a vaginal delivery and or 1000 ml for a C-section. Massive obstetric hemorrhage requiring blood transfusion in this patient increases the risk of postpartum pituitary necrosis, Sheehan syndrome. The pituitary gland hypertrophies, hypertrophies through pregnancy in order to maintain adequate blood supply of pituitary hormone, an adequate supply of pituitary hormones during gestation and in anticipation for lactation following delivery. This hypertrophy increases pituitary metabolic and oxygen demand, which places it at increased risk for injury in the setting of deficient perfusion, like postpartum hemorrhage. The most common presenting symptom following necrosis of the pituitary is failure to lactate, which is secondary to insufficient prolactin concentration. The anterior pituitary also secretes ACTH, TSH, LH, and FSH, and GH. Pituitary necrosis results in an overall decreased production and secretion of all these hormones and can present with a variety of symptoms like weakness, lethargy, genital atrophy, and menstrual disorders. Next.
Okay. 22-year-old primary gravid woman, 38 weeks of gestation, is admitted to the hospital in labor. She had a spontaneous rupture of the membrane 32 hours ago. At 35 weeks of gestation, the results of rectovaginal culture of the group B streptococcal infection were positive. Group B streptococcal infection were positive. Her temperature is 101. Lungs are clear to auscultation. Lungs are clear to auscultation. The uterus is tender. The uterus is tender to palpation. There is no costovertebral angle tenderness. A fetal heart sound is shown. Cervix is 80 centimeter effaced. Cervix is 80 centimeter effaced and 3 centimeter dilated at -1 station. Her leukocyte count is 19,200. With the left shift microscopic examination catheterized sample, no WBC or bacteria. Which of the following is the most likely cause of these patients' heart tracing? Fetal tachycardia, isn't it?
Why? Wait, one. Yeah, tachycardia.
Yeah, there is infection, maternal fever, maternal. Okay.
Okay. So it is A. Choriamnionitis. Fetal tachycardia is defined as heart rate greater than 160. Fetal tachycardia can be caused by hypoxia, fetal anemia, intrauterine infection, and maternal medications. Choriamnionitis is a polymicrobial bacterial infection of the fetal membranes and commonly occurs in the setting of premature or prolonged rupture of membrane more than 18 hours prior to delivery. Okay. Risk factors for prolonged rupture of membranes include young maternal age, smoking, low socioeconomic status, history of STI. Chorioamnionitis typically presents with fever, abdominal pain, along with uterine tenderness to palpation on physical exam. The amniotic fluid may be foul smelling. Leukocytes on lab evaluation is also typically present leukocytosis. Complications include infection of the fetus with pneumonia, bacteremia. Treatment involves administration of broad-spectrum antibiotic, most commonly ampicillin and gentamicin, and induction of labor. Um, Following delivery, the neonate will need close monitoring for infection, with the majority require antibiotic therapy. It is not E. What is it? Uteroplacenta insufficient can cause late cell, yeah, and is most
Your
commonly caused by
uh, mnemonic like veil chop, isn't it? Like late
uh-huh,
deceleration is uterine placental insufficiency, isn't it?
yeah,
Okay.
yes, can cause late deceleration, is most commonly caused by um, hypertension, cocaine use, placental abruption, anemia, diabetes, cigarette smoke. It would not explain the patient finding of uterine pain, fever, and leukocytosis. Makes sense. Okay, next.
Okay. A hospitalized 42-year-old woman gravid to para 1, 40 weeks of gestation has a cervix that has remained 6 centimeters dilated and completely effaced for 3 hours. The fetus has a estimated weight of 3.4 kg and in the left occiput posterior position. Contraction every 5 minutes last 30 seconds and 30 millimeter in pressure. Her first pregnancy ended in spontaneous vaginal delivery, of a 3.6 kg boy for 3 years ago. Which of the following is the most likely cause of the arrest of the liver? Okay.
Mm, Prosomia, is it more than okay, whatever? Okay, so the answer is hypotonic contractions. Labor consists of three defined stages. First stage, the start of labor, contraction and cervical change until the completion of cervical dilation and effacement. So contraction and cervical change. The second stage, time from complete cervical dilation to baby birth. And third stage, delivery of placenta. First stage of labor is divided into latent and active stage based on the degree of cervical dilation, with the active phase beginning after 4 centimeters of cervical dilation is achieved. The active stage of labor can be protracted, which occurs when the cervix is dilated at less than 1 is dilating at less than 1 to 2 centimeters per hour. Okay. As seen in this patient, or arrested, in which case there is no cervical change for greater than 4 hours with adequate contraction, or no cervical change for greater than 6 hours with inadequate contraction. Okay. Abnormal progression of the active stage of labor can be caused by hypotonic contractions, cephalopelvic distortion, and non-occipital anterior fetal presentation. Okay. Inadequate contractions are defined as occurring less than 3 or 4 times in 10-minute periods with a strength less than 200 Montevideos. That's contraction every 5 minutes. Hmm. Montevideo units are calculated by summing the strength of each uterine contraction, blah, 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 over 10 minutes. This patient demonstrates contraction every 5 minutes that are 30 in pressure. Okay, so Montevideo is what?
60.
Mm, so is what do they do? They do the minutes time the pressure, right? Or am I wrong? No, I'm saying it wrong.
So how they
No,
calculate? I don't know how Montevideo is calculated.
calculated by summing the strength of
Strength of
each
each.
contraction over 10-minute period. The strength of each contraction over 10 minutes. I don't know what that means.
Strength of each contraction. So like 10 minutes per normally less than 200 Montevideo, isn't it? Uh, oh, okay, you read, then we will discuss. We
Okay.
need to understand
This
this.
this indicates that the inadequate hypotonic contraction are mostly because of this patient protraction of active labor. Protraction of the active phase of labor can be managed with oxytocin to augment uterine contraction and prostaglandins to assist in cervical opening, whereas arrest of the active labor is managed by C-section.
Okay, can you see how this Montevideo unit is calculated? The Google. In here, like we know
Oh,
that there is three defined stages of labor, isn't it? Like the first stage is onset of true labor pain, like onset of true labor pain to the full dilatation of the cervix and effacement. And the second stage is full dilatation of cervix up to the baby's birth, and the third is the delivery of the placenta. Okay, three contraction in 10 minutes, 55, 45, and 60. So they actually do addition. So
okay.
how we will found this? Contraction of every
Mm.
5 minutes lasts 30 seconds, and it is 30 millimeters. So 30, 30, and 30, 90.
But why you do it 3 times?
They, in the calculation they have done three times. Okay,
Oh,
sorry. Yes, I have found. Like contraction every 5 minutes lasts 30 seconds, and it is 30 millimeter in pressure, isn't it? So we need to calculate
mm-hmm.
up to 10 minutes interval. So 5 and 5 is 10, and it is 30. So 30 plus 30, it is 60. 60 Montevideo. You got my point.
Okay, 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 okay.
So normal is less than 200 Montevideo,
Mm-hmm.
or it is inadequate contraction. Occurring less than 3 to 4 times in less than 10 minutes period of a strength less than 200 Montevideo unit.
Okay,
Okay, leave
okay.
it.
No, you got it. It's what you said. So it's 60. Normally, less than 200 is inadequate
Normal.
contract. No,
No,
it's
not
required.
sorry. Normally less than 200 is inadequate contraction.
It's inadequate. So 60 is inadequate. So that means it's inadequate contraction. Um, yes, that's the thing. It's not occiput posterior position can cause protraction or arrest of labor, but more commonly presents with molding of the fetal head and caput cecidium. While present in this patient, it is less likely responsible for the protraction of labor than her weak uterine contraction. It's not the fetal macrosomia or the cephalopelvic disproportion can cause protraction or arrest of labor. It more commonly presents with molding of the fetal head and caput cecidium. Yeah. It is less likely as she previously had a successful vaginal delivery of the larger fetal. Yes, that's true. Fetal macrosomia is defined as fetal weight more than 4,000 and can cause protraction or arrest or labor as a result of inability of the feature to pass to the pelvic inlet. However, this fetal is 3,000, making this one so it's not more than 8. Okay, okay.
Okay.
So macrosomia is more than 8. Okay,
Macrosomia is more than 8.
yeah. What's this one? Okay, okay, I think we got it. Okay.
And like I want to add two things. Like what
Mm-hmm.
is protracted labor, what is arrest of the liver.
Mm-hmm.
So abnormalities in the active phase of the labor, we can divide into these two things, like protracted labor and what can I say? Arrest of the labor. Protracted labor is labor progressing slower than the anticipated. Like what is our like if it is less than 1 centimeter, if labor progression is less than 1 centimeter per 2 hours, it is called protracted labor. However, a slow but progressive active phase of labor demonstrating cervical changes at least every 4 hours and do not immediately warrant need for the cesarean delivery. We have seen that the in protected labor we can wait, but in the arrest we need to do the cesarean delivery. So protracted labor is less than 1 centimeter per 2 hours. So we will wait for 4 hours. Like 4 hours, we need to check. Okay, what is arrest? Arrest is less defined as less than 6 centimeter dilated, at least 6 centimeter dilated with ruptured membrane and no cervical change in 4 hours with adequate contraction, or no cervical change in 6 hours with inadequate cervical contraction. You got my point.
Got it.
So cervical change uh, in 4 hours with adequate contraction, like no cervical change in 4 hours in adequate contraction, and no cervical change for at least 6 hours with inadequate contraction. Okay, that's the thing. Okay,
Okay.
a 27-year-old primary, a 27-year-old woman, gravida 3, para 2, 33 weeks of gestation, comes to the physician because she has fluid leaking from her vagina for 2 days. 2 days. Her fetus is active. She has not had any uterine contraction. Examination shows a uterus consistent in size with 32 weeks of gestation. Fetal heart rate is 140 per minute. Fetal heart rate is 140 per minute. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Okay,
Okay, so is sterile speculum exam of the vagina. Damn. Pre Premature rupture of membranes is the rupture of the amniotic sac before the onset of labor. regular contractions for cervical change. If it occurs before 37 weeks of gestation, it is termed preterm premature rupture of membranes, PPROM. So there is PPROM. Patients typically report a gush of fluid or steady leakage of fluid from the vagina. Initial evaluation includes a sterile speculum exam of the vagina, which may show pooling of fluid or leakage of fluid from the cervicals. Nitrazine testing of the fluid will disclose a pH 7 to 7.3, so acidic, I guess. And ferning, which will be seen on microscopic exam. Ultrasound can also be utilized to determine the amount of residual amniotic fluid, which will be decreased in the setting of rupture of membrane. Risk factors These factors include previous premature rupture of membrane, a vaginal cervical infection, and cigarette smoking. Treatment involves expected management with betamethasone administered to accelerate fetal maturity in patients with gestational age less than 34 weeks. Screening for STI and strep agalaxia group B should be completed. Antibiotics are commonly given prophylactically because of an increased risk of chorioamnionitis. Other complications include preterm birth, core compression, abdominal placenta, and postpartum endometritis. It is not fetal fibronectin test is used to determine whether a patient is in true or past labor. It can determine the likelihood of delivery. Oh wait, fetal fibronectin test used to determine whether a patient is in true or false labor and can determine the likelihood of delivery within 7 to 10 days of testing when present in the cervicovaginal fluid. Okay. It does not play a role in
So it
determination of
excludes true and false labor
hmm?
pain, fetal fibronectin testing.
What do you mean? I don't understand.
Like somebody comes to you with saying that he has labor pain, and he
Mm,
told you that there is fluid leakage of fluid, but you do this test and you found that he has no labor pain. He has not true labor pain. Sometimes false labor pain, sometimes people can come with false labor pain, isn't it? So
mm,
you can use this test for differentiate true and false labor.
mm-hmm, mm-hmm,
Okay.
mm-hmm. Okay. Next.
87-year-old woman who is home a nursing home resident brought to the physician 1 week after the staff noticed a vaginal mass. She has dementia, Alzheimer's disease, appears distorted. Examinations show partial prolapse of the uterine cervix through the introitus. The uterus can be easily pushed back into the pelvis. There is no cervical ulceration. Which of the following is the most appropriate next step? What is it prolapse?
Yeah, probably prolapse. But she's 87, so do we just take the uterus out?
Should we need to do surgery in this age?
Maybe not. I don't think so. Probably not.
Okay.
Okay. 25. Insertion of a vaginal pessary. Normal pelvic support is caused by the action of several pelvic muscles and ligaments, including the levator muscles, urogenital diaphragm, perineal body, endopelvic fascia, uterosacral and cardinal ligaments, anal sphincter, urethral sphincter. Defects in this pelvic support may result in urogenital prolapse, which is because of the loss of connective tissue and muscular support of the uterus, paravaginal tissue, bladder wall, urethra, or distal rectum. These factors for pelvic support defects include collagen and other connective tissue disorder, vaginal delivery, menopause, prior pelvic surgery, increase in abdominal pressure like in obesity or chronic constipation. Signs of and symptoms include vaginal mass, vaginal pressure, perineal discomfort, urinary or fecal retention or incontinence. Management may include insertion of a vaginal pessary, which is mechanical device that provides pelvic support along with pelvic floor muscle. If non-invasive therapies fail, surgical treatment with reconstruction, fixation, and uterine suspension or hysterectomy can be considered. It is not cervical amputation or vaginal hysterectomy may be used in the treatment of pelvic support defects. However, surgical management of uterine prolapse is typically considered later after attempting non-invasive management. These techniques may be difficult to ethically justify in an elderly person with dementia, depending on the patient's goal of care and relative safety for surgery. Okay.
Okay. A 27-year-old woman. Can you hear me?
Yeah.
Is it clear or is there any problem?
No, I can hear you clearly. Yeah. It's
Okay. A 27-year-old woman, gravida 3, para 1, aborta 1, 32 weeks of gestation, comes to the physician for a routine prenatal visit. She reports that she felt little movement. She reports that she felt little movement of the fetus during the past 18 hours. Pregnancy had been uncomplicated. She weighed 59 kg. Prior to the pregnancy, BMI is 22 kg per meter square. She has had a 9.5 kg weight gain during her pregnancy. Her pulse is 72 per minute. Her blood pressure is 128 by 74. Her fundal height is 29 centimeter. No fetal heart tones are heard on Doppler. On pelvic ultrasonogram, cervix is closed and not effaced. Urine dipstick shows no glucose or protein. Ultrasonogram confirms because ultrasonogram confirms the presence of fetal cardiac activity in otherwise normal appearing male fetus. The patient and her husband choose to return to await spontaneous labor. 4 weeks later, the patient comes to the physician because of episodes of light vaginal bleeding, but no contraction, light vaginal bleeding, but no contraction. External electronic monitoring shows mildly irregular contraction every 20 to 30 minutes. The cervix is closed, not effaced. The presenting part is soft and 2 -2 station. Lab hemoglobin 11, hematocrit 32, platelet 90,000, and fibrinogen. Which of the following is the most appropriate next step?
between A and D. I don't know. Um, C-section, induction of labor.
Like it is fetal death. Now you need to decide, isn't it?
Yeah. Between C-section or induction of labor. Oh, yeah.
I don't think so. We use C-section for pulling out the dead baby.
Okay. Ready?
Yes.
So it's induction of labor. Stillbirth refers to demise after 20 weeks gestation and can occur before or during delivery. Um, Antepartum intrauterine fetal demise commonly presents as in this patient with decreased fetal movement and lack of fetal heart tones on exam. Ultrasound confirms the intrauterine fetal demise. In high-income countries, stillbirth is most commonly caused because of chromosomal abnormalities, heteroplacental insufficiency, and maternal medical disease, whereas it is more commonly caused by maternal infection, preeclampsia, or obstructed labor in low-income countries. Delivery for antepartum and intrauterine fetal demise is based on the mother wishes, with immediate induction or delayed natural delivery. Both options in the absence of any complicated medical issues. Labor typically begins 1 to 2 weeks after fetal demise. Coagulation abnormalities can occur with delayed delivery because of the release of tissue factor from the placenta. This can lead to DIC, which presents with thrombocytopenia, prolongation of partial thromboplastin and prothrombin, increased D-dimer concentration, and decreased fibrinogen concentration. Given this patient early mild contraction, nerve aches, prolonged retention of a non-viable fetus, and risk for the development of coagulation abnormalities, induction of labor is the most appropriate step. C-section delivery can be used to deliver fetus in the setting of arrest of labor, cephalopelvic disproportion in placenta or vesa previa, but is not typically required in intrauterine fetal demise. Following fetal death, there is a collapse and maceration of the fetal body, which allows most fetus to undergo successful vaginal delivery. Okay.
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 A 25-year-old primary gravid woman in labor, 24 weeks of gestation. Treatment with tocolytic agent is ineffective. She has used crack cocaine during pregnancy. Cocaine most likely altered the uterine contractility by which of the mechanisms? What is crack cocaine? How it does?
Sympathomimetic.
Sorry,
It increase it increase I think it increase sympathetic.
like what is this thing like crack cocaine? Is it like taking things nasally?
It's a you yeah, it's a drug. It's like a powder and you put it in
But
your nose.
okay, that causes nasal perforation. Like in the movies, what
Uh
we have seen, like people are
mhm.
taking cocaine like a white powder. Is it that?
Uh-huh. Uh-huh. Uh-huh.
Okay.
Okay, let's see. Increasing catecholamine. Crack cocaine is a sympathomimetic that increases sympathetic tone to the inhibition of norepinephrine reuptake in the presynaptic neuron. This results in increased synaptic norepinephrine concentration and consequent increased adrenergic receptor activation. This increased sympathetic tone results in the activation of alpha 1 receptors in the uterus myometrium, leading to increased contraction. This abnormal increase unregulated contraction of uterine smooth muscle can result in onset of preterm labor. Tocolytic therapy with common agents such as terbutaline, beta-mimetic, magnesium sulfate, prostaglandin inhibitors, and calcium channel blockers are often ineffective at reducing uterine contraction, as they do not directly inhibit the sympathomimetic activation of the uterine myocytes, which is increased in the setting of cocaine use. Cocaine use in pregnancy can also cause uteroplacental insufficiency with low birth weight and intrauterine growth restriction, miscarriage, aborted placenta as a result of sympathomimetic stimulation and resultant vasoconstriction.
So what will we give if the patient comes with this crack cocaine? They
I don't
said
know.
the beta blocker, like the tocolytic agents, tarbutaline, Maxalf, prostaglandin inhibitors, and calcium channel blocker like nifedipine are often ineffective at reducing uterine contraction.
I think you
So
just do delivery. If it's above the placenta, you just do
it
delivery,
is
right? So you
it is
just do.
24 weeks of gestation only.
Yeah, I don't think there is anything here. You just do the deliver. You just
Like
give the thing
in the
that you
in the
give.
cocaine toxicity, what we actually give, like benzos. Do you remember?
Yeah, but this is
But benzodiazepine is
yeah,
contraindicated in here, isn't it?
yeah. It's not the same. You don't. It's not this. You're not. This is a pregnant woman, so you're not treating it like just cocaine toxicity.
Okay.
This we're trying to. Yeah, I think here you just do. Because abrupto placenta, you just do delivery. So if this causes abrupto placenta, I'm pretty sure you just do delivery. You
Yes.
just have
If
to
if
deliver.
if abruptio placenta, then delivery.
Yeah.
If it other cause like IUGR or uteroplacental insufficiency, how we will manage like now?
Mm. I think you still have to do just delivery. I think, yeah, I think whatever is the cocaine thing, and then the patient is already in labor, have to do delivery.
We will do the delivery.
Yeah,
Oh,
I think
okay.
so. Yeah, I don't see it here, but yeah.
Next.
Okay, next.
2 days after spontaneous vaginal delivery. 2 days after spontaneous vaginal delivery of a healthy newborn at term, a previously healthy 37-year-old woman, Gravida 1, Para 1, has left-sided pleuritic pain and a progressive shortness of breath. Her pulse is 94 per minute, respiration is 20 per minute, blood pressure 96 by 55 millimeter of mercury. Pulse oximetry on room air shows an oxygen saturation 89%. Breath sounds are normal. Bilateral examination of the extremities show mild edema, no tenderness. Hemoglobin is 9.1, leukocyte is 15,000, arterial blood gas is uh, pH is 7.45, alkalosis CO2 is low, and oxygen may be normal. Okay, so respiratory alkalosis.
Ready? Oh, sorry. I'm gonna write this down. Ready?
Yes.
Okay, it's thrombus within the pulmonary artery. So, like I said, P. Pulmonary embolism P classically presents with pleuritic chest pain, shortness of breath, um, tachypnea, hypoxia, and clear breath sounds, often in a patient with DVT or a non-hypercoagulable state like pregnancy. Small pulmonary emboli may present only as pain or shortness of breath and may be asymptomatic with normal vital signs. By contrast, large emboli infarctions generally cause more severe symptoms, tachycardia, tachypnea, hypoxia, and potentially hypotension if significant enough to obstruct the cardiac output. The resultant tachypnea is demonstrated on arterial blood gas analysis as an acute respiratory alkalosis from hyperventilation leading to diminished arterial CO2 as hypoxemia because of the ventilated but not perfused affected lung. Pelvic venous congestion is a common source of DVT in pregnancy. Large pulmonary emboli may be seen on chest X-ray by secondary signs such as wedge-shaped areas of infarction or via Westermarck sign of unilateral oligemia. Uh, though the standard of diagnosis is CT pulmonary angiography. In pregnancy, a ventilation perfused and scan may be preferred as this technique is safer for the fetus, less radiation exposure. The ECG in pulmonary embolus often shows sinus tachycardia, uh, and if there is right heart strain can exhibit right axis deviation, S wave in lead 1, Q wave in lead 3, and inverted T wave in lead 3. S1, Q3, T3. Treatment depends on the risk for bleeding to the patient, but includes anticoagulation and surgical thrombectomy. It is not a bronchial smooth muscle contraction described by the physiology of asthma and reactive airway disease. Obstruction to airflow through constructed small airways presents with shortness of breath and wheezing, hyperventilation. Hyper or hypoventilation is severe and generally vital signs reflecting tachycardia, tachypnea, exam shows wheezing and respiratory distress. This patient breath sounds are clear, making this unlikely. It's not C, fetal squamous cell in the pulmonary veins. Describes amniotic fluid embolism. Hmm. A rare, a rare and life-threatening complication that occurs when amniotic fluid enters maternal circulation. It classically presents with acute severe shortness of breath, after metastatic hemodynamic stability, DIC during labor. It will be less likely to occur 2 days following delivery. Okay, next.
So it is P, pulmonary embolism.
Mm-hmm.
Okay, next.
Mm-hmm.
A 4.5 kg male newborn is delivered at 41 weeks of gestation to a 37-year-old woman gravida to para 1. Pregnancy and labor were complicated by mild preeclampsia with infusion treated with infusion of magnesium sulfate during labor. Electrical electronic fetal monitoring showed a normal fetal heart rate and pattern. A pudendal block with 1% lidocaine was given for analgesia. The newborn was delivered with forceps after the fetal heart rate decreased to 80 per minute in the second stage of labor. The shoulders were firmly impacted. The newborn was delivered after 3 minutes using special maneuvers. Apgar scored 3 and 8 at 1 to 5 minutes respectively. Examination shows no motion tenderness at the right side of the face, even when the child cries. Which of the following is the most likely cause of this finding?
Ready? Ready?
Wait 1 second. Okay.
Okay. So it's facial nerve injury. Assisted vaginal delivery is indicated for a prolonged second stage of labor. Second stage, so it's when the baby's coming down, or in the setting of fetal distress, as seen in this patient with fetal bradycardia. It can be completed using vacuum assisted delivery or metal forceps. Successful assisted vaginal delivery requires a dilated and effect cervix with rupture of membranes and engage occiput. Vacuum assisted delivery is typically chosen when extraction is expected to be easy, although this relative contraindicated in fetus with gestational age less than 34 weeks. Forceps are chosen when the extraction is expected to be more difficult and require fetal head rotation. Vacuum assisted devices can cause scalp lacerations, cephalohematoma, brachial plexus injury caused by shoulder dystocia, retinal hemorrhage, and intracranial hemorrhage. Forceps assisted deliveries can carry the risk for laceration, intracranial hemorrhage, facial nerve injuries, skull fractures, ocular injuries. Mother can also suffer from laceration, urinary tract injury, anal sphincter injury, facial nerve injury from forceps delivery will present in the neonate with unilateral facial paralysis as seen in this patient. It's not brachial plexus injury, most commonly present with herb Duquesne palsy following birth because of traction placed on the upper brachial plexus trunk during delivery. Herb Duquesne palsy commonly causes adduction of the shoulder, internal rotation of the arm, extension at the elbow, pronation of the forearm, and flexion of the fingers and wrists. It does not cause facial muscle paralysis. Cerebral palsy is a neuromuscular disorder that is commonly caused by hypoxia during delivery, and although it is also associated with congenital abnormalities, preterm birth, perinatal stroke, maternal smoking, intrauterine growth restriction, it typically presents with dyskinesia, involuntary movement, ataxia, spasticity. However, the diagnosis is not often clinically apparent at birth. Intracranial hemorrhage is an unusual complication of vaginal delivery in term infants. Um, it could potentially present with unilateral partial paralysis, but would likely occur in association with contralateral hemiparesis, extremity hemiparesis, which is not seen in this patient. Okay.
So take home is forceps uh, assisted delivery can cause facial nerve injury, intracranial hemorrhage, skull fracture, and ocular injury.
Okay.
So if nothing given in regarding face, then intracranial hemorrhage can happen, isn't it?
What do you mean? I didn't understand your question.
Like option C and D both goes with the forceps delivery.
Yeah, but D says intracranial hemorrhage, you're going to see contralateral hemiparesis too. So you're going to see cranial nerve palsy, but also like
Contralateral extremity hemiparesis. So
yeah,
like
other nerve
stroke-like feature.
stroke like features, I guess. Yeah. Mhm.
Good. And if we do vacuum assisted delivery, then scalp laceration, cephal hematoma, and brachial plexus injury can happen.
Mhm.
Okay, next. A 30-year uh, a 42-year-old woman, leiomyomata uteri comes to the physician for a follow-up examination. She has not had vaginal bleeding, pelvic pain, loss of urine. Examination shows no abnormalities. Examination shows no abnormalities except for a uterus consistent with the size of 15 weeks of gestation. Hematocrit 41. Pelvic ultrasonogram confirms leiomyomata uteri. Which of the following is the most appropriate next? After menopause, fibroid decreases in size, isn't it?
Mm-hmm.
And she has no symptom.
Mm-hmm. Ready?
Okay.
So it's observation. What am I? Right here. In this patient with asymptomatic fibroids, the most appropriate management is observation only. Fibroids are common benign tumors of uterine smooth muscle. In most patients, fibroids are asymptomatic, though in other patients, fibroids can lead to abnormal uterine bleeding, pelvic pain or pressure, and or reproductive dysfunction. Physical exam may demonstrate an enlarged lobulated uterus, and the presence of uterine fibroids can be confirmed by ultrasound. Since fibroids are benign and may regress over time or with menopause, asymptomatic lesions should be managed expectantly. For symptomatic fibroids, hysteroscopic or abdominal myomectomy is often first line. Um, yeah, in patients who do not desire pregnancy, alternative treatments include oral OCPs, um, GnRH agonist in hysterectomy, oral contraceptive and GnRH agonist can lead to rebound symptoms when discontinued to allow for conception. It's not myomectomy is a first line treatment option for symptomatic fibroids, which involves surgical removal of one of multiple fibroids. GnRH agonist therapy, oral contraceptive, and hysterectomy are also treatment consideration for symptomatic fibroids. In patients who do not desire to preserve fertility. Okay. However, any of these options should only be considered for patients with symptomatic fibroid, not this patient without it.
Okay.
Okay.
A, a 19-year-old college student health service because of 5 day history of ulcer in the inner side 5 day history of ulcer in the inner side of the vulva. 6 weeks ago she was diagnosed with herpes simplex virus 2 involving the left side of the vulva. At that time, testing for chlamydia trachomatis and Neisseria gonorrhoeae was negative. HIV antibody testing and rapid plasma reagent were also negative. She has completed 10 days of valcyclovir therapy. She has not been sexually active since her last examination. Today she reports that her herpes sores are gone. Pelvic examination shows 1 to 2.5 centimeter non-tender ulcer, slightly raised edges and shallow base at the perineum. Which of the following is the most appropriate next?
Ready?
Okay.
So repeat rapid plasma reagent. A variety of STI may cause formation of a non-tender genital ulcer. This includes lymphogranuloma venereum caused by chlamydia trachomatis L1, L2, L3, syphilitic syphilitic chancre caused by treponema, and granuloma inguinale caused by Klebsiella granulomatis, non-tender genital ulcer. In contrast, genital herpes and chancroid caused by HSV and Haemophilus ducli are both characteristic of painful genital ulcers. The organisms causing painful ulcers can be distinguished clinically based on ulcer appearance. For example, the ulcer in chancroid is exudative and accompanied by significant inguinal lymphadenopathy. Um, yeah, the ulcer of granuloma inguinale, also called granuloma donovanosus,
Tonovenosis.
is beefy, red, friable, and often induces additional ulcers on a position of skin. The ulcer of what? Granuloma inguinale. Which one was the normal inguinale? The Klebsiella one. Okay. The chancre of primary syphilis is shallow with a clean base. Thus, the ulcer described in this case fits best with the ulcer of primary syphilis, and the testing for this infection should be pursued. Untreated syphilis demonstrates multiple stages with varying symptoms, including primary with painless chancre, as described, secondary with fever, lymphadenopathy, condylomata lata, and tertiary with tabes dorsalis, aortitis, and gummas. Serologic testing for syphilis is first performed with non-treponemal tests such as VDRL or RPR. During the early phases of primary syphilis, VDRL or RPR may be negative. Given this the patient supporting clinical evidence for primary syphilis, RPR should be repeated. These tests are typically performed as a screening test, and if positive, should be followed by a treponemal test such as fluorescent treponemal antibody absorption test. HIV infection may be transmitted as co-infection with syphilis. In fact, infection with one may increase the likelihood of transmission of the second. Repeat HIV may be warranted in the future of this patient, but it's not necessary at this time for diagnostic purposes, as the pain that's also described is most likely because of syphilis and HIV. Okay.
Okay.
Yeah.
A 37-year-old woman, gravida 2 para, 128 weeks of gestation, comes to the physician for a routine prenatal visit. She has a history of operative procedure and her pregnancy has been uncomplicated. She has 3-year history of hypothyroidism and well controlled with levothyroxine. She is 5 feet 4 inch tall. She weighed 77 kg prior to her pregnancy. BMI was 29 kg per meter square. She has had 14 kg weight gain during her pregnancy. Vital signs are within normal limits. Physical examination shows no abnormalities. Fundal height is 30. Ultrasound show moderate polyhydramnios. Which of the following is the most likely cause of this patient's finding? She has diabetes.
Maybe not. It's
Where it
something
is
with
written.
hypothyroidism, levothyroxine, hypothyroidism, levothyroxine. And between that and fetal renal agenesis. I don't know. Okay.
Okay, let's see. May
So So yeah, it's maternal diabetes mellitus. Diagnosed maternal diabetes mellitus. Polyhydramnios refers to excessive concentrations of amniotic fluid volume and an associated increased uterine size relative to gestational age. It is associated with an increased risk for fetal anomalies, placental abruption, preterm labor, postpartum uterine atony. It should be suspected when the uterine size and fundal height are larger than expected for gestational age. Polyhydramnios can be diagnosed on ultrasound exam through measuring the amniotic fluid index. An amniotic fluid index greater than 24 centimeters indicates excessive amount of amniotic fluid. Polyhydramnios can be idiopathic or associated with a variety of disorders, including maternal diabetes mellitus, fetal infection with parvovirus B19, twin transfusion syndrome, fetal chromosomal or structural abnormalities such as duodenal atresia or anencephaly. Fetal anomalies are the most common cause of polyhydramnios, but are typically apparent on ultrasound. Antenatal testing such as fetal ultrasound with biophysical profile should be performed to evaluate for underlying fetal abnormalities, along with amniocentesis to evaluate for chromosomal or genetic abnormalities. Um, the
The main,
frequency of
yes.
The frequency of antenatal testing depends on the severity of the polyandramnios. Given the patient's history of uncomplicated pregnancy until this point, the most likely cause of this patient polyandramnios is undiagnosed maternal diabetes mellitus. It is not fetal, well, aneuploidy can present with polyandrous but would be expected to also have apparent congenital abnormalities on ultrasound. For example, when combined with intrauterine growth restriction, polyandrous is commonly as a result of trisomy 18, which will present with round feet, cystic hygroma, neurotop defect, facial defects, of all of that. It's not fetal renal agenesis will cause oligohydramnios. Okay, sorry. Yes, yeah, because of the absence of urine production, not oligohydramnios. Yeah, okay.
So only clue in here, like the baby's, like she is at 28 weeks of gestation and the fundal height is 30. That's the clue only.
No, that's just a clue that there is but they already told you it's polyhydramnios.
Polyhydramnios can happen in fetal aneuploidy too. So how you can differentiate?
Because fetal aneuploidy, they did an ultrasound right here where it says they did ultrasound for.
Ultrasound shows polyhydramnios. Like in fetal aneuploidy, we can see the. If we do ultrasound, what will happen? If the ultrasound can. Okay, I got it. You want to say like the ultrasound can detect the abnormal fetus.
Yes.
Okay,
Mhm.
fetal.
Yes.
Oh, sorry,
Good.
anomalies can. Okay, yes.
Yeah. Mhm.
So they have done anomalies. Okay,
Mhm.
next. A previously healthy 19-year-old A previously healthy 19-year-old woman, gravida 1, para 0, aborta 1, comes to the emergency department because of 2-day history of severe pelvic pain and past like vaginal discharge. Severe pelvic pain and past like vaginal discharge. Her last menstrual period was 10 days ago. She has had 2 sexual partners during the past month and uses an oral contraceptive. Her temperature is 101, pulse is 110, respiration is 18, blood pressure is 120 by 75, abdomen 120 by 75. Abnormal abdominal examination shows tenderness to palpation of the lower quadrant with no guarding and rebound. Speculum examination shows irritated vaginal and cervical mucosa with copious purulent discharge coming from the cervical os. coming from the cervical os. Bimanual examination shows cervical motion tenderness and bilateral adnexal tenderness. Rectovaginal examination show a fluctuant mass in the cul-de-sac. In addition to Neisseria, gonorrhea, and chlamydia trachomatis, which of the following is the next step in the management?
Hmm.
I am in between C and D. Why
Oh,
hysterosalpingography?
wait, what is hysterosalpingography again?
To
What?
see the fetal, like in infertility, it is done
Mm-hmm.
to see the fallopian tube is intact or not. Like hysterosalpingography is
Mm-hmm.
that thing. You put the dye through the uterus and you see that the dye is coming through the fallopian tube or not. If dye is not coming, then
And then pap smear doesn't make sense. There's nothing. HPV, she doesn't have any ulcers. Um, and then HIV,
CMT is tender, like cervical motion and
which one?
bilateral adnexal tenderness. Looks like the,
Yeah, oh,
so
it
isn't
looks
it
like what?
like PID? She
Yeah, it
has,
looks like PID. Mm-hmm.
so how
But they
PID
already,
can happen?
PID will be Nigerian chlamydia, but they're already testing there for Nigerian chlamydia. HIV, I don't know if HIV can cause PID. It doesn't, I don't
HPV
know, it doesn't,
cannot cause PID.
I don't think so. I mean, I don't,
I don't know.
I
I
don't,
don't know. Truly, I am just
the other,
asking you.
yeah, I don't think, I mean, I never, maybe, but I've never seen it. And then HPV will have the no- the come down those things, those
HIV cannot
words.
cause PID. Not like
I don't think so. But HIV, I feel like there will be like lymphadenopathy and all these things. And HPV, though, you'll see the warts or the I don't know.
but
I don't
she
know. I
has
would have
two
gone with
sexual,
Nigerian chlamydia.
she has two sexual partners.
Yeah. Yeah. So maybe HIV. Maybe that would be the only thing that will go to HIV. And she has post vaginal discharge. I don't know. Okay, let's see. Pick one. Pick HIV. You're right. It's HIV.
But
Antibody
I picked
testing.
D.
There's oh yeah. No, it can be HPD, HPV. It just doesn't
Yes,
make sense.
yes. I
Um,
haven't changed my answer. These
yeah.
days,
Like,
what am I thinking? Just given. Right, I am not thinking about the right and
just
wrong.
give it.
I am doing.
No, but
I am planning
that's
with
the
new
best.
and new strategies.
Yeah,
Sorry.
but I think that's the best way. I think that's
Yes,
the best way.
I
Like
think
you
that
just
in the
yeah,
exam there is no
mm,
chance of changing answer. Whatever
yeah.
you picked. Like there is
Okay,
no
good.
time. I don't think I don't have that time to
Yeah.
come again and see that answer and then again read and
Yeah.
deal with that. I don't think
Yeah.
that I will get this time.
Yes. So just pick and then you can mark it. And then at the end, if you have time, okay, then you just go to the ones you mark.
But
But
in terms of solving your world, what is happening? Like I'm
mhm,
doing like very stupid mistakes previously when
mhm,
I have done this question. That
mhm.
was right at that time, but now I am picking. I am trying to be extra clever and picking the wrong answers.
I
So
think also the way we think of on those CMS form is different from the way we used to think on your word.
yes, they are.
Ye-
It is totally different.
Yes, because here I feel like we trained our mind. Okay, let's not overthink it. The answer is right there. It's on the question. Let's not overthink it. But in your word, I used to. they always try to trick you somehow. The question is long. You need to know the concept deep, deep, you know. So it was like you had to think about it for a while. But here it's just like don't overthink it. Just pick something. Just read the question. The answer is on the question. If you are between two answers, just read the question again. There is one thing that's going to give you the difference between the two
But
answers.
in CMS, you have that opportunity of reading this question
Yeah.
once or twice. But in the U world,
Yes.
I think that
You,
after reading once, it is very tough to read again.
yes, you cannot read it. So I feel like from my experience taking the exam, two
Yes.
times, I feel like this CMS is more like the exam.
Exam oriented, isn't it?
It's more exam oriented. I feel like UWorld is good the way we were doing it without timing ourselves, without, so you deeply know the concept, you know how they can trick you, the many ways they can trick you, and all that. It was good. But this is more like the exam, the CMS thing, I
Even
think.
like even CMS, I think that CMS is closer to the exam. Like CMS
Yeah,
is, yes. So
yeah,
I think that we need to be master in these concepts too. Like in the U world, if you know the
yeah.
concept, they can trick you. But in the CMS, if you know the concept, they cannot trick you actually. If you know
So,
the, like, some of the concepts are new. That's why we missed. Like the first question of this block, do you remember the succensurate placental lobe? I don't think that I haven't
yes,
done
yes,
any
yes.
question in the U world like that.
Any questions? Yeah. I know I studied it, but I haven't done any question. I hadn't done any question.
So
I
like
hadn't
this,
done any question. I know.
these are the different words. Like your mind will catch this kind of word easily if you found in the U world. But I don't think so. We
Yeah.
haven't done such question.
We haven't done so questioning, but you see that it was an easy question. You just needed to know the
Know
concept.
the
You just needed to
concept.
know
Yeah.
what. Yeah, you just needed to know that key phrase that you highlighted. That key phrase. You just needed to know that. So
Yes.
that question shouldn't even take us like 2 seconds. Because once you see that sentence, you know, oh, it's succinct. You just click it and move. So I don't think an easy question like that you'll find it in your word.
Yes.
I don't think so. But it's definitely something you can find on the exam. Like I know a lot. I know some of my MBME questions came like exact same question was on the exam. Like
Okay.
probably one or two, not that many, but
But
yeah, one or
what happens like as we do NBME once, not like deeply. So
two. Mm-hmm.
we actually made
Mm-hmm.
mistakes in the exam. You got my point, what I'm trying to say. Like what, how we
No.
do the U world, we do not go the NBME in
Mm-hmm.
such a way. We do the NBME like, oh, it is an exam. So we just see the question like the
Yeah.
exam purpose. You got my point.
Okay.
So I think that
I don't.
like we have done two NBME question and we try to read all the things. We
Oh,
try,
yeah, yes, we did.
yes, that
Mhm.
actually helps. I think so.
Yeah, yeah,
If
yes.
we like if we read all the NBME in such a way and we try to recall all the concept of the NBME up to exam, then we can do something. We can get extra marks from that. I think
Yeah,
so.
yeah. I mean, definitely. I mean, two questions. I guess it's something. If you already know two questions on the exam, but yeah, definitely. Me, all the MBMs I've done, I always try to review them after. Like I
Yes,
always try. Yeah, yeah, it's good to review them after. You don't have to read all the like we were doing. You don't have to read all the answer choices, but the ones where you were like a little bit confused, like I didn't even know if it was. Yeah, just go over them. Yeah.
yes.
Mm.
So that's
Okay.
the thing. Okay, no problem.
Yeah. But if I had to pick now that I've done, because I never done the CMS before. So now that
But
I'm doing it,
but I have done CMS and I told you that this is important because I
yeah,
feel like when I
no,
after doing the CMS, then I jump into the NBMA, then I found that It's kinda similar.
Yes, yes. Now that I'm doing it, I'm like, yeah, this is definitely closer to the exam. I mean, the MDMEs, I think that would be the closest you get to the step two exam. But definitely, this is also closer because there were some questions like that. It was just you either know the concept or you don't know. There is no point of you wasting. It's just like a two sentence question. You know it or you don't know it. There is no point of you thinking. There is nothing you can make up there or try to know. Just you know the concept or you don't know. Just pick something and move on. So yeah, that's true.
Okay.
Okay,
You want
Nigeria.
sorry?
Yeah, go ahead.
Okay, okay.
You were
Oh,
saying.
okay. We haven't read the explanation. We are talking. Okay.
Okay. Neisseria and chlamydia can both cause vaginitis, cervicitis, PID. Vaginitis typically presents with mucopurulent discharge and pruritus. Cervicitis presents with similar discharge, but also with red, friable cervix and cervical motion tenderness. When infection spreads to the fallopian tube and ovaries, PID with purulent cervical discharge, uterine and nasal tenderness, and systemic symptoms such as fever can happen. If left untreated, PID can be complicated by tubovarian abscess and intra-abdominal abscess, presenting with focal tenderness and fluctuant. Oh, that's the mass. Okay. Treatment of PID involves antibiotics such as cephalosporin, tetracyclines. Risk factors for PID and other STIs include adolescence, multiple sexual partners, and not using barrier contraception such as condoms. Patients diagnosed with PID should be tested for other common STIs as well, such as HIV and syphilis. Oh, that's what they were asking. Compromised mucosal barriers in the setting of genital infections present as an entry point for HIV, for which these patients should be tested. Is not, what would we confuse about? Oh, HPV is a STI, is a sexually transmitted viral infection that can cause cervical, vulvar, and penile anal carcinoma, as well as condylomata cuminata. Testing for HPV can be done in conjunction with pap smear cytology, but is not a part of routine diagnosis for active STI. And hysterosalpingometry is performed in the evaluation of infertility to evaluate for patency of the fallopian tube, detect developmental abnormalities such as unicornuate or septate uterus, and evaluate for presence of polyps, submucosal myomas, or intrauterine adhesions. Okay. Okay.
You want to go for breakfast or
Yeah.
okay.
Yeah. Okay.
Okay. Okay,
See
bye-bye.
you. Bye bye.